My name's Kara Papa, and I'm with Native American Fatherhood and Families Association also. But I wanted to go ahead and introduce that we're going to be having our second panel, which is engaging families. Our second panel, which is engaging families across the lifespan, and our moderator is Leo Nolan. I can't pronounce that. From the Mohawk Nation. So is he here? Is Lee Nolan here? Okay. Okay. So I'm going to introduce the first person while we wait for Lee. He'll be back in just a moment. Our first speaker is going to be Crystal Key, and who is Navajo, and Allison Barlow, who is from Johns Hopkins, who's here from Johns Hopkins, and they're going to be talking about family spirit, early childhood intervention.
Thank you so much. I am so privileged to stand here with Crystal, who really is the heart of Family Spirits movement now across the country. But there are many, many people in this room who have been champions for this program. If you've had any involvement at all with Family Spirit, could you raise your hand? Thank you, all of you. It's an amazing group of people over many, many years where this has come together. So. I want to brag a little bit about Crystal. So the little girl that is a vision of hope on this slide is Crystal's daughter. And I'd like you to know that I stand beside an incredible colleague and an incredible mother. But Crystal is on a lot of our opening slides, Crystal's daughter, because she gives us such incredible hope. I really took the words of Mr. Pooley to heart when he said, that in order to work in Indian country, you have to show love and you have to welcome people. So I want to start by welcoming all of you always to Johns Hopkins and to our Center for American Indian Health. I know a lot of people travel to the East Coast for different conferences. Know that we're here. We're close to Washington, Philadelphia, New York. You are always welcome here. I'm just going to tell you a little bit about our center. For more than 3 decades, there have been people from Johns Hopkins School of Public Health working with tribal nations across the country. And the center was founded in 1991 by an incredible individual named Matu Santosham, who is oceans away today. I wish you were here, but he's certainly here in spirit. But when he founded the center in 1991, he did so through an MOU with Indian Health Service, and that MOU was really to leverage our resources to do the best work we can to raise the health status, self-sufficiency, and health leadership of Native people to the highest possible level. And pictured on the right, and he's I don't know what happened to the photo, but anyhow, that's Matu hugging that child, and I think the most important part is the hug, so that's why it's in there. So our original partners are the tribal nations pictured here, Navajo Nation, White Mountain Apache, and San Carlos Apache. They have been behind the center's work, the leaders of the work, truly, since our origins. And more recently, the Santo Domingo Pueblo has joined the family. But now the center's work, thanks to the incredible innovations that these tribal communities have created, has moved across the country to over 90 tribal communities across 16 states. We employ more than 80 Native American staff and faculty who are doing the outreach work in their communities. So while our center has an administrative headquarters here in Baltimore, many, many more of us are not here. They're in their own communities working and doing and being. The center really takes an approach to build programs co-created with tribal communities that work across the lifespan. And this is just a quick illustration of different program models that have been designed over the years. The one at the bottom is Family Spirit, which is what we're here to talk to you about today. So this is nothing new, but there's been a changing landscape in American Indian health. And we know in the 1970s and 80s, the highest tolls that took Indian children were infectious diseases. And that is no longer true. There has been an incredible epidemiological shift, and now those things that are taking the lives of children are behavioral and mental health inequalities. And we know all of that is tangled up in all the determinants that Dr. Warren and Dr. Bullock and Ms. Feinday spoke about, these incredible historical and modern determinants of poor health equality. Again, this information here is not news, but it's staggering. It's ridiculous, actually. When we look at the death rates of Native people 0 to 25 years old are 2.5 times higher. Suicide rates to 4 times higher. In some tribal communities, 13 times higher. Incredibly staggering statistics. And we have to face this. It's the truth that we have to stare in the eye. So when we started working in the early 1990s with White Mountain Apache community, we had received monies that were only to address poverty. So here again, Dr. Warren said that public health is traditional medicine. So those tribal communities that we began this work with, this unrestricted funds to work on poverty, said, we need to think about how we're going to break these cycles. How are we going to break these cycles of, at the time, poverty? But here's what was the picture of the problems that cycled. And it was very clear to those communities that the way to break these cycles is to start with unprepared parenthood. And again, this concept of parenting and familyhood is so large and so elastic in tribal communities. There's such an opportunity to work across generations. So the sort of Western side of research has said a whole lot of what tribal communities knew intuitively, and that is poor parenting in early life leads to a whole host of problems in later life. And that early life is this key time for behavioral redirection. And again, when we look at, from the Western literature, how do problems in early childhood forecast problems in later childhood, you see everything in the red on the right-hand side are the things that are now the current behavioral mental health disparities that are affecting Indian youth. And again, if we can start upstream and work in early childhood, what an opportunity we have to break this cycle. So I've stolen this slide from other presentations that Dr. Bullock has given, but we know that stronger parents raise stronger children. And there has been an amazing evidence base that was led by Dr. David Olds, who was the originator of the Nurse Family Partnership Program, that actually has been able to show that if we can intervene in early life, this will affect the child's life course through to young adulthood. So there's such hope. We have the answer. We know what can work, and it's intuitive to Native communities to work in this very important developmental period to promote health across the lifespan. So now I'm going to turn it over to Crystal, who's going to tell you a little bit about the Family Spirit Program.
Thank you, Allison. And to all of you guys who are here today, Crystal Keen, Nanish Dejetka Bahan Shlonki Ane Bashichin, Twitch Eatney, Dashitego, Hashkan Hotzone, Dashanele. And so I'm actually from the Dene Nation in northern Arizona, and I'm based out of our Chinle office and work as a training and implementation manager for the Family Spirit Program. So thank you all for just taking time today to be with us. Family Spirit has been something that has just been very near and dear to my heart for the last 7 or 8 years. And I have really just invested a lot of time in, because I've seen the impact that this intervention has made on numerous families in my community. So we have had a long history of developing this intervention over 20 years. We began in 1995 at the calling of some of our community members, our outreach workers, our community leaders, when they said that we needed to have some sort of intervention that it's designed to strengthen families in these communities. And so since that time, we've gone through 3 randomized controlled trials, and currently now the intervention is supports families from prenatal to the child's 3rd year birthday. And since the end of 2009, I think we began doing some dissemination of the family spirit intervention with a few programs. But really our dissemination effort also has taken off. We're one of those programs that are just very new in the whole home visiting field, but we started doing that at the end of 2012. We've had, most of our participating communities were based in the Southwest with the White Mountain Apache, Navajo Nation, and San Carlos Apache. But these were just really the folks that had guided our processes in designing this intervention and designing our curriculum. So how do we affect change? So we know that there are so many things that just a lot of our colleagues mentioned earlier that really affect the way that families grow. And so we really try to create our model based on focusing our efforts on providing parent training, coping and problem solving, conflict resolution, depression and addressing depression and substance abuse, and we really had to work in partnership with different programs and made referrals to those services that address the needs of families. So our intervention is actually really takes into account what some of our presenters this morning talked about, and that is family. And so whenever we are thinking about families, of course, we're not just thinking about just the mom and the father. We're talking about everyone else that is impacted as part of this home that families live. And so whenever the families are feeling supported, that really trickles down to just providing support to the next generations of people. So a lot of times, if we're able to provide not only if we're able to address some of the issues that our families deal with, such as substance abuse, we really try to include support for families that really just also improve their parenting skills and address any issues that really impede their parenting. And so again, some of those factors included substance abuse, depression, parental skills, and just having poor coping skills. So the design, the intervention. So we actually had developed 63 lessons that were taught from prenatal to the child's 3rd year. So imagine the support that a lot of these families get from the time that before they've even had their child and up until that child turns 3. And so that's over 3 years of having someone come into their homes and to teach them. We really have, we developed a curriculum that was able to support that. And so our intervention also includes home-based outreach. This really helps to overcome so many barriers that a lot of families have to deal with, whether they're living in rural communities or urban communities. And some of those barriers could include just access to health care. But if we can bring services to these families by going to their homes, a place where they're feeling the most comfortable, where we can also tap into the other, providing information to other families that support this child, that was really the direction that we wanted to go. And so our community health workers, our paraprofessionals, our home visitors, we actually have trained them to also work with a lot of their, engage a lot of their community service providers. And so these were people from mental health, these were people that were providing interventions for substance addictions. These were people that could provide some financial support and really engage them in providing services to these families. The community health workers helped families address any barriers that got in the way of them to be effective parents. And so the program is actually designed for paraprofessional family health educators. We knew that across Indian country and across the country itself, we actually have had to deal with just the shortages of nurses on reservations. So this intervention took that into account. So if you ever come out to the Navajo Nation, it is going to be hard for someone to stay in Chinle for over, 10 years because the nearest movie theater is, 2 hours away, or to go get groceries, you have to drive an hour, And so it only made sense for us to design our intervention with the people that came from the community, the people that knew the culture, the language, and understood the barriers that a lot of our families have had to deal with. And so by investing and training in our own community health workers, we were able to leverage the support and the trust that these families needed to feel cared about. And so the home visitors were actually the agents of change, and they have had just really, they became a really powerful force in just helping families to make changes in their lives. Our 63 lessons include so much information, from the basics of just infant care to teaching families how to set goals, to learning about family planning and reproductive health, to talking about conflict resolutions, to talking about their futures. There are several things that whenever at families, we have some core essential skills that is really just to keep our babies clean, to keep them safe, to provide them food. But with this curriculum, not only are we addressing those skills, but we're also teaching them to be teachers to their children. They are learning the essential skill of being the teacher in shaping their child's development. This is basically a photo of what our curriculum looks like. And so it's pretty comprehensive. It weighs about 26 pounds. So not only do our home visitors have a really great tool that they can utilize to teach, but they also have really good arms because they have to carry this thing around. But we have our lesson pages, we have a lot of supporting materials that just help them to be the best educators that they can be, from reference manuals to participant workbooks and evaluation tools. So our curriculum has really been, it's such a gem because it came from the partnership with our community members, not only just our stakeholders, but true community leaders. And in shaping these lessons, we've had to create stories that created dialogue between families and the health educator to solve problems. And so our curriculum also has illustrations that were designed by a Navajo and Apache artist. And then we also include just outtakes for local cultural activities and additional resources throughout the curriculum. So this is basically a design of how the lesson is presented. And there's a page that the home visitor utilizes to teach the content, but there's also graphics and interactive activities that the family gets to participate in. Okay, so I'm going to turn it back over to Allison now.
I have to do a little shout out to Dr. Arya Crump and Dr. Kathy Yetz, who were really champions behind this work from National Institute for Drug Abuse Prevention. But Family Spirit's undergone 3 randomized controlled trials, and I'm going to show you the data from all 3, but with a focus on the study design from the 3rd trial. So there were 322 mothers that we enrolled, and they were randomized either to receive the Family Spirit intervention or what we called optimized standard care. And that was developed in partnership with the community advisory boards. Basically, the moms received transportation from a paraprofessional called a family health liaison to every prenatal and well baby visit. And during those transportation sessions, they were given information about local services to address any of their emergency needs. And that was held constant in both groups so that we would be able to attribute differences between groups to the Family Spirit intervention. So these were the baseline characteristics of the group of mothers and children who enrolled. And you'll see very young, the average age of the moms was 18. For about 3/4, it was their first child. Very few were married, although many live with the baby's father. Not very many were still in school. And a sort of staggering thing that we learned is more than half had lived in 2 homes or more in the past year, so highly mobile. 1/3 of them had elevated depression scores at baseline and very high lifetime drug use rates. And we were, at the time, particularly concerned about seeing these rates of meth, which in the previous Family Spirit trial, we saw very low rates of meth. So this was during a period of time when meth was really infiltrating the communities. So we looked at outcomes across 3 major domains. The parenting, of course, which was the primary aim was to promote parenting, but also we knew there were these really huge challenges that stood in the way of moms being successful parents, which included those high rates of depression and substance use and other risky behaviors. So we were able to show that significant differences in maternal knowledge and self-efficacy, reduced stress, improved home safety attitudes, but not improved home safety. Why not? Because they were moving all the time. They didn't have control over their home environment. But where the rubber really meets the road is what happened to their children. And the good news is that the kids had fewer social, emotional, and behavior problems and lower what we call clinical risk of behavior problems over the life course. And I'm just going to explain that a little more closely. But going back to that theoretical model, this is just a way to picture how really working at a community level through a community outreach worker on parenting affected all these other issues within these family contexts. And that's what I think is so amazing that, again, one person visiting a home can have this incredible impact. So just a closer look at the children's outcomes. So we measured the children's outcomes with a tool called the ITSE, the Infant Toddler Social Emotional Assessment. And that assesses for three domains of behavior problems. And the big fancy names are externalizing, internalizing, and dysregulation, but this drills it down to help understand, well, what does that look like in a child from 1 to 3 years old? So externalizing would be the child would be more outwardly aggressive, have early troubles with peers, would maybe be more hyperactive or impulsive, and you can read down the list for the other domains. Internalizing, it would be the earliest sort of precipitants of anxiety, withdrawal, separation distress. And dysregulation is about all those sort of daily functions. So having trouble eating, sleeping, being kind of bothered by light or by scratchy labels, those sensory sensitivities. And what was super exciting is what we learned afterwards is that the children whose mothers participated in the program show clinically lower risks for those 3 problem domains. And what you're seeing in the light blue bar are the Family Spirit children, and what you're seeing in the orange bar are the children who did not get the program. And what we're really excited about is that red bar is for national norms, and you saw how high the moms' risks were when they started, all those baseline characteristics, young moms, moms who had signs of depression. We already know that they lived in very unstable housing situations. And here their kids were, in 2 of their domains, meeting national norms, and in 1 domain, significantly reduced externalizing problems. And this is a super busy slide, but here's the really cool news. So we talk a lot about historical trauma and epigenetics, but what we learned here is that the mothers who entered this trial at highest risk for substance use, their children did as well or a little bit better than kids whose moms did not have high risk for substance use at the beginning. So again, this is the hope, right? So it's true that these families are entangled in incredibly challenging contexts, but with this type of a program, we can reverse these cycles. So quickly, Family Spirit is now endorsed by HOMV, which is the Federal Home Visiting Review, and NREP, which is the National Registry for Evidence-Based Practices and Programs. And I really want to highlight the middle block, which is of the home visiting models, Family Spirit has one of the highest participant retention rates. And that is because of these family health coaches from the communities who love the mothers they serve. And that is what's making a difference. So, Crystal, you want to talk a little bit about something?
So currently, we actually are probably in about 98 tribal communities right now. And we are also, and all these 98 programs are across 16 states. And we are also in 2 non-native communities. We're in Chicago, Illinois, where Family Spirit is utilized with Latino families and African American families, and then in St. Louis as well, so with the Queen of Peace program in St. Louis. So where do we go from here? Do you want to talk about this?
We just wanted to let you know what the future of Family Spirit is. So right now we're working to understand how we can tailor Family Spirit for individual parents and families' needs. And we're also adding new modules to address emerging needs, early childhood obesity, early childhood caries, looking for ways to use technology to increase the efficiency. And we're starting a new program. It doesn't have yet its own name, but it's going to be working with mothers and daughters pre-puberty, so working upstream, that third sister that Dr. Warren talked about. And in terms of recommendations for early childhood for the future, we have to think big about the benefits. This really has, people say there's no silver bullet, but home visiting and early childhood intervention is a silver bullet, actually. And task shifting is so important. If we don't have enough professionals in tribal communities, we've been able to show that paraprofessionals can do the work upstream that's going to prevent all the treatment in the future. And sustainability. We have to be creative about funding streams, and I'm so glad Dr. Carroll's here because she's going to be a champion, I hope, at Medicaid and Medicare for looking into ways that programs like this can be sustainable. So thank you so much. We really appreciate it.
Hi, I'm the moderator. I was moderating in the bathroom, sorry. Anyway, my name is Leo Nolan. I'm from Onondaga. I have a few years of experience working at HHS and Indian Health Service, and I'm very happy that Rear Admiral Buchanan, Chris Buchanan, the Director of IHS, will be with us this afternoon. This is an opportunity, I believe, for us to not only hear what he has to embrace about Indian families and what he has said in his 2, I don't know if you know this or not, but both in March and April, he held a tribal leaders teleconference status update, which you can sit in on if you want to. And both of those, both the March and April updates, he mentioned Family Spirit. And he recognizes the good work that Johns Hopkins has done, and I think it's great that he does that. However, he's one person in the overall 65,000 people who work at HHS. So I think one of the key things that you all need to think about is how you can help us promote these kind of programs across the spectrum of where influence can be held. Senate Committee on Indian Affairs, the House Subcommittee on Indian, Insular, and Alaska Native Affairs, certainly with Secretary Price, who was at the IHS tribal budget meeting about 3 weeks ago, spent a good hour and a half there, and has seemed to have huge interest in Indian issues from health all the way through other kind of programs that HHS has. So it's great that we have those kind of folks there, and I think you all can help us with that moving along. I think we're going to have a switch here a little bit. I think Sean Brotherson is going to start, I believe. Yeah. And Sean is at the University of North Dakota State University and has done a lot of work in childhood education, parenting, family stress, and well-being of family education and family policy. And he wrote the co-editor of a book, Why Fathers Count. And one of the reasons we can help us determine that is the Indian Health Service does have the authority to establish an Office of Indian Men's Health, which the last administration didn't do, but hopefully President Trump will think about that, and maybe we can get him to do just that in one of his tweets. But the authority is there. The authority is there, and I think it's really important for us to really think seriously about what that could do to help our Indian male constituents, as Mr. Pooley has stressed over there. Mr. Brotherson.
Good afternoon. I appreciate the opportunity to be with you from the Northern Plains here in the eastern United States. I always enjoy being with Al. We go back quite a few years, I think. Dallas, I think, was our first meeting quite a few years ago, and a large Head Start conference is where we met. And I'll talk about that maybe in just a minute. But I enjoy Al because he likes to make everybody laugh. So I thought, well, maybe I can start by sharing a story like Al did. I haven't been scalped recently, so that's a little bit of a problem. But when I was growing up, I come from a family of 6 children, had an older brother, 20 months older than me. And we used to do quite a bit of archery out in the backyard. And I didn't reference my Native ancestry in the materials, but I have some Native ancestry I'll talk about in a minute. And so anyway, we were out there one day, and we were shooting arrows at a bale of hay, and I went down to get my arrow, and my brother turned around. He wasn't paying attention, and he shot his arrow, and he hit me in the side. And so, Al, I can say I've been shot by an Indian warrior if I say that my brother shares my Native ancestry. So, as we think about this topic, I've worked with indigenous populations throughout my career as a family life educator and researcher. But that's not how I originally came to associate with Native populations and to love them. And I remember having this conversation. Al probably doesn't remember this conversation, but I was the founder with a colleague of what was called the Dakota Fatherhood Initiative. And that's how Al got connected with us as we were talking about early on in his work and our work about our common interest in father involvement. And he said, hey, you guys live up there in the Dakotas. That's an area where there's a lot of indigenous peoples that you should be thinking about working with. And I said, well, how do you think I should come at that? I said, Al, sometimes when you come into the tribal community and you're coming in like me, Caucasian, a white man, they're not sure how to approach it. And Al said, well, do you have Native ancestry? And I said, yeah, it's back about 7 or 8 generations. It's Mohawk. And the story I tell about that is my wife has Seneca ancestry. And so when we got married, because part of the Iroquois Nation, they would marry within tribes, Seneca and Cayuga or things like that. And I said, so even though we're 7 or 8 generations removed from that ancestry, we're carrying on the tribal tradition. And so anyway, she agreed to join me, and I'm a family scholar, and I said we need to have a little family laboratory. So we have 8 children of our own. I'll show you one here in just a minute. And I talked to Al about that, and he said, what other connections do you have? And I said, well, my dad spent 3 years of his life living on the Navajo Nation. And I have a sister who's adopted, who's Kickapoo, and my aunt is Navajo. And I said, so I have some connections. And then Al said this one thing, which has always stuck with me. He said, if you are connected in any way to Native peoples, this is what I say to everybody that we work with, and I'll say it to you. You belong to us, and we belong to you. And so then my hesitation about feeling comfortable about working in that context went away, because Al extended that invitation, that welcoming invitation that he talked about earlier. I'd like to start with this theme of families from a quote from a book from Joseph Marshall, The Lakota Way. Up in the Northern Plains area, there's a number of tribal communities that are Lakota, Dakota, and Nakota. And he says, the three words, Lakota, Dakota, and Nakota, have the same meaning, an alliance of friends. They represent geographic as well as linguistic distinctions. A cornerstone of Lakota culture can be summed up in the words family and kinship. Family is the backbone, the foundation of our culture. We are given substance, nurtured, and sustained by family. Kinship goes beyond family and is the connection we feel to the world at large and everything in it. And so when we talk about family relationships needing to be the foundation of what we do, I think that's speaking from within the Lakota culture and other cultures. I think that's very much part of what's important to be thinking about. Let me see if I can advance this. So I'd like to spend just a few minutes highlighting implications of childhood experiences and relationships for lifelong wellness. That's already been done well by my colleagues, Dr. Warren and Dr. Bullock, so I won't spend a lot of time there. Share some foundational elements of supportive developmental environments. Share a few case examples from the landscape of family-focused interventions and some of my experience with that. And then just some thinking from that direction. So if we think about children, here's a picture of my youngest child. And so I think when we start in this work, we need to think about children. We need to think about where they are starting and the start that we help them to have in life. Because if we're concerned about lifelong health and wellness, we need to be concerned about the trajectory that we send them on in their journey through life. I like this quote from Khalil Gibran, "You are the bows from which your children, as living arrows, are sent forth." And when I first encountered that quote, I just liked it because it was poetic. And then as I became involved in the field of early childhood education and family strengthening programs, it became more important to me. And then I remembered that experience with my brother. There was a point to the story, which is thinking about that. If children are sent forth as living arrows, in a sense, how stable is the bow that is sending them forth, and how important is it to their trajectory? And if you've been involved in archery and you try to pull back the string on like a compound bow, it requires some strength. It's not easy. And if you don't have strength, you'll go like this and you'll waver all over. And then the trajectory will vary quite widely. And so thinking about that stability and how we get there is really important. So we've talked about ACEs, and you've seen this today. But I want to kind of make the transition to that next step we've been talking about, which is overcoming adversity and toxic stress. How do we help people experience change that's important? So here's another example of looking at the idea that early childhood experiences, adverse childhood experiences, have impacts across the lifespan. We've talked about this occurs in a very sensitive developmental period. 90% of a child's brain development takes place in the first 5 years of life. And adverse childhood experiences can occur across a whole variety of categories. Well, how do we get to the next step? Margaret Mead said the solution of all adult problems tomorrow depends in large measure on the way our children grow up today. So if we look at foundations of supportive developmental environments, you've got the area of prenatal and neurodevelopmental factors, the social economic environment, but a really critical one is relational health. And what they asked me to talk about a little bit is relationships. Dr. Andrew Garner notes this. He says, he's a pediatrician, social emotional buffering is the primary factor distinguishing level of stress with children. And toxic stress occurs when there's an absence of social emotional buffering. Now, as a developmental scientist, I love that we use all these different terms. I think earlier Dr. Bullock referenced something that said inadequate adult support. What does that mean? It means love and commitment and consistency. Yuri Bronfenbrenner, who's a well-known developmental psychologist, basically said, summing up everything in this area, he said, each child needs a person who is totally crazy about him or her. So that's what we're talking about, all right? 3 examples of models that focus on relationships. Here's the Harvard Center on the Developing Child framework, which you should become familiar with. You've got that model of health from preconception all across the lifespan, focusing first on biology of health, and we've talked about physiological adaptations to stress and things like that. It's cumulative over time. But notice that number 2, stable, responsive relationships, safe, supportive environments. And nutrition has also been discussed. So there's one that focuses on health. Let's go to the Centers for Disease Control and Prevention. They're essentials for childhood effort. Notice the language is very similar. Safe, stable, nurturing relationships and environments are the CDC's strategic direction for child maltreatment prevention. So here we're talking about child welfare, child maltreatment. Let's go to another one. Okay, Center for the Study of Social Policy and their Strengthening Families, Protective Factors Framework, Nurturing Relationships, Parental Resilience, Social Connections. So emphasizing the importance of relationships in all of these. I'm going to share just quickly examples from 3 programs that I am familiar with and have been connected with. The first is a primary intervention, the North Dakota Building Connections Project. Second is targeted, kind of the Fatherhood is Sacred program, and then a tertiary program, the Nurturing Parenting program. Back in about 2005, 2006, I was a co-investigator on a federal grant, the Building Connections Project, which we did in the Standing Rock tribal community in North Dakota. And it was focused on parent education, healthy family relationships, and youth development in the Lakota community. And Don talked earlier about some of the challenges within those communities in terms of health disparities and socioeconomic disparities and difficulties. This was a program where we were focused on, it was a culturally tailored program based on traditional culture, focused on parent education and healthy relationships. This is a picture of individuals who are involved in the program. We also were focused on youth development, so focused on positive adult-child interactions, working with youth to teach cultural skills, archery, horsemanship, things like that. So this is an example of a program that was universally available that we developed and we're operating in the Dakotas. Okay, second example, okay, the Fatherhood is Sacred program, and Al has talked a little bit about that program. What I wanted to show is I was involved in just some early initial assessment of this program. So we designed a retrospective survey, and we had about 85 men who'd been through the program talk about their experience in the program. Okay, so notice what they themselves perceive as a result of being in this program in areas related to their parenting. I'm attentive to the needs of my children. 57% prior to the program, 78% at the conclusion of the program. Sound knowledge about parenting, 46% to 86%. Commitment to being a good father went from 57% to 98%, right? So this kind of tells a story. It's not a randomized controlled trial story yet, but it's telling a story. I've changed my behavior to become a better parent, 42% to 85%. I am respectful and supportive of the child's mother, 47% to 72%. So this is an example of that kind of program. Now, in North Dakota, the state program selected for use with families where children are at risk of child abuse or neglect is the Nurturing Parenting program, which I've been involved in evaluating for the past several years. One thing that we've found, when we go back, is in the state of North Dakota, about 25 to 35% of our participants are Native American. However, the program is not culturally adapted for them. So we're just starting research to look at how does the program for them compare to other participants in the program. On average, this is with individuals on average, we see increases, for example, in parental empathy, less likely to use corporal punishment, and something like this. So this is a construct. How many are at risk in terms of empathy toward child needs? About a third start out in the at-risk category. By the end of the program, which is about 15 weeks, it diminishes to about 6%. So my summary from all of this is, let me get to it. 100 years from now, it will not matter what my bank account was, how big my house was, or what kind of car I drove. But the world may be a little bit better because I was important in the life of a child. And the relationships that we build with children, whatever our relationship to those children, is what ultimately I think will make the difference for their lifelong health and well-being. Thank you.
Excellent overview of 3 programs and what Sean has been able to do over his career. So thank you for that, Sean. Next we have Mark Pooley, who is currently a patrol sergeant in Arizona and also works with NAFA and been a tribal prosecutor at Gila River, Salt River, Maricopa. Has both a bachelor's degree from NYU and a master's of education from North Dakota, from Arizona University. So, Mark, thank you.
Get my time right so I don't go over. My name is Mark Pooley. Just like they said, I'm in Arizona. I'm actually the son of Al Pooley, and so I've known him my whole life. And a lot of the stuff that I'm going to say is the things that I have heard from him, but also have seen with my own eyes and experienced it myself. And so I'm going to talk about is about our second course, which is called Linking Generations by Strengthening Relationships. Now this course is designed and enhanced to teach parents and children how to have healthy relationships. And during the course of the program, it reminds the parents several things. Number one, it teaches healthy relationships within the family. And number two, it reminds the parents we have the same purpose as our forefathers. Just several presentations, they talked about that, talked about the history and the people and how they got through a lot of this adversity. I'm actually going to give an example that is given in our curriculum. But before I do that, I want everyone, when I ask this question, I want you guys to think about yourself and think about your own situation. And the question is, how is your integrity? And I'm going to read this. It says, many of us know people who are kind, thoughtful, courteous, and patient with friends and colleagues. They are a pleasure to be around, and everyone admires them. But often, when they return home, their behavior and demeanor change. They are no longer kind and patient. Instead, they are critical, rude, impatient, demanding, and often just downright mean to the people they say they love the most, their families. These people treat friends, associates, colleagues better than their own families. These people must renew their integrity. Individuals must commit to developing and strengthening integrity in their lives in order to become honorable men and women. As I read that to you, I don't know if you guys know someone that meets that example. But when, for us in the program, we come across a lot of people who don't even know what the word integrity is and have a hard time trying to not only live it, but even to teach it to their children. Just like they said earlier, I'm currently in law enforcement. I've been in law enforcement for 16 years. During that time, I've been a detention officer on a reservation. I've been a tribal prosecutor, police officer in a major city. I've also been a detective. While a detective, I investigated robberies such as home invasions and street jumps, shootings, stabbings. I also worked with the FBI on the Joint Terrorism Task Force, and I also was a homicide detective. And I bring that up because in my line of work, I have seen a lot of trauma. We keep talking about trauma. And as I'm talking, or as I was listening to the people talk, I noticed about the children and the trauma. And it doesn't matter if you're black, white, or native, when you have such things as domestic violence in the home. As an officer, as a first responder, a lot of my officers, we go into these homes. And it's amazing to see how the parents treat each other. But if you always look at the kids, they're always hiding somewhere. They don't have a place for safety, and they're scared. And the first thing I tell my officers to do is always let the kids know that they're safe. And it usually breaks down some barriers, and it helps the children to have a safe place to be. Now, again, my thing is in law enforcement, so I apologize to bring this in, but I tell my officers several things. I tell my officers that you only have control over two things when you go to these type of calls. Number one is your integrity. Your second thing is your professionalism. And when I tell my officers this, I ask them, how do you get that integrity? And usually it's grounded. It has to be grounded in true principles. And these are usually learned in the family way before they even became a police officer. Most of our officers, they come from good families, stable families. Not all of them, but they have to understand true principles. The next one is they have to have a good connection with their current family. The type of work that we do daily is if you see things that happen negative at work, and then you go home and you don't have a strong connection with your family, you won't last long to be a police officer. It's just the nature of our business. Talking about the program when we bring this in, and I'll read this again. Parents should encourage their children to learn about their forefathers and telling stories. We said that many times as we look at our families and our generations and how we were able to overcome a lot of this. And it comes back through our families. But it goes through several things. Number one, what they stood for. Number two, their values, what their values were. And number three, what was important to them, which was their families. And when the people hear this message and they understand what they're here for, they develop a sense of identity and purpose in life. My father, he has 6 children, and 3 of the 6 were in law enforcement. And one of the things that he teaches, or he told us, and I actually share this with my officers quite often, and there's 3 things he tells us. Number 1 is to go home at night safely to your family. Number 2, you are an officer of the law and you represent justice. And what does that mean? That means you have to be fair. When you go to a call, you have to let the people know, you have to hear both sides and make a good, just decision. And number 3, and this is the most important one, is when you meet people, it's usually at a time at their lowest position. Either they're homeless or mentally ill. And this is the key. He says, when you do this, you need to restore their human dignity back on the street, because sometimes you're the only person or individual that you're going to actually show them that they have some kind of hope. NAFA is currently in the criminal justice field, and many of our Native youth, and why? Because many of our Native youth and adults, they're incarcerated. I know the judge was saying that our population of youth is, they're all incarcerated or in foster care. And again, NAFA has been working with the courts, probation, corrections, and the police. Many of our communities on the reservations, they're in a state of chaos. They deal with mental illness, domestic violence, substance abuse, child abuse, and suicide and domestic violence. I'm going to share a personal experience with you when I was a tribal prosecutor. And it's funny is this is several years ago, probably 12, 13 years ago, but a lot of the data that was showing about who else is raising our children. And I remember I was in my office, and we had just removed a child from the home. And this was a fortunate one where we were able to put the child back into the home, which was not to the grandmother, but to the great-grandmother. And the great-grandma was sitting in my office, and she was an older lady, and she just started crying. And as I talked with her, she told me that she's doing this all by herself. Her own daughter, the grandmother, and her great-granddaughter or granddaughter, they were both incarcerated. And so we were trying to brainstorm, trying to find ways of letting it be a successful removal. And as we sat down and talked with her, we started to ask, well, do you have any help? Do you have any, are you married? And come to find out that alcoholism was very prevalent in this family. Her husband, or her father, husband, and brothers, most of them had died from alcoholism. And so she was doing it all by herself. And as we started to brainstorm, and again, I was very young, and I'm still young, but I didn't know what to say to this lady. As we started to talk, we actually started to talk about our heritage, about looking back at our forefathers and how they got through this. And one thing that was amazing is once she understood the strength of her family, of her previous generations, she started to change like that. Then she started to look at the generation of her children or her grandchildren and great-grandchildren. And we started talking about the happiness that brought into her life. When she did that, or when we did that, she had a new desire or a new thing of hope. And that hope is what made her say, I could do this. And we met occasionally, and the sad thing was we actually ended up severing the rights of the mother because she was addicted to methamphetamine. One thing I told her that, as through our conversation, is that this generation is different than the previous generations with different substance abuse. I know a lot of people, they come from, on the reservations, we have a lot of families who are addicted to alcohol. And that took a lifetime to get to that point. Now with the new drug of methamphetamines or cocaine or heroin, they take and change a family within a year. And I've seen it with my own eyes, and it's very, very sad. I know I'm running out of time, but I wanted to let you guys know that we're very honored to be here and to be part of this cooperation of brainstorming and also getting different ideas and seeing what's working and what's not in Indian country. I hope that the Native American Fatherhood and Family Association could be part of your communities and help bring some of those traditions and knowledge that we have forgotten from our forefathers to bring it back to our families and to our Native people. And I think as we do this, that we will continue to be successful. And just like my father said, our purpose and the purpose of life is to have a happy and safe family. And thank you very much.
What Mark brings is an important aspect of parenting and just living in your respective communities, having respect for these agencies who are really there to help you, not incarcerate you, so to speak, but making sure your children understand what they can do and how they can help you. And that's important, and respect for what they're trying to do. These guys men and women put their lives on the line every day, and it's really important for us to recognize that they're there to protect us and keep us safe. We next have Melissa Walls, who's at the University of Minnesota Medical School in Duluth, and is a visiting associate professor here, I believe, for this year, academic year, Anishinaabe, and she's going to tell us a little bit more about how they've been promoting health in her community that she's from. Thank you, Melissa.
Well, I had to fight for this time spot, the one right before lunch, after a long morning, a heavy morning. Okay, we're in a school of public health. I have to do this. I was getting tired sitting there. Could everybody please stand up for me? Stand up, throw your hands in the air, wave them around like you just don't care. Yeah. That's as good as it gets. Yes, yep. Okay, good stretch, right? All right, we can sit down. So there's this literature out there that says for every hour you sit, you should stand up for at least 2, and I think they've even reduced that now. Like for every 20 minutes you sit, you should stand up for 1 or so. If you need to stand up in the middle of my talk, as some of you are doing, I won't be offended. So Bonjour, good morning. Anin, Melissa Walsden, Dishinakaz, and I am Bois Forte and Couchiching First Nation Ojibwe on my mother's side, and German and Swedish and Scandinavian mix on my father's side. And there's a funny story about the Swedish ancestry, which I can tell you over lunch, and that is that I'm potentially next year going to be on a Swedish reality show. So I might be famous in Sweden, but not this year. I didn't get picked this year, for those who knew that story. So you knew me when? Before I was Swedish famous. And I have to say, my grandfather really makes fun of that. He said, Melissa, you've been working on this stuff your whole life, really giving back to our community and trying to do this work with the tribes. And the white man wins again. He takes you to Sweden and you become a star overnight for that little bit of blood. So anyway, I digress. Okay, what do I have going on here? Oh, so it's a gathering about the family. I'm going to throw pictures of my family at you to start. And I want to begin by pointing out, okay, so Anne, you were saying this there. This lady, that's my grandma, Gladys. That's my son, Brady, that she's hanging on to there. Now, let's see, where are some of the Hopkins people who have the t-shirt? All in the back. So, Nicole, I don't know, could you run up real quick with that t-shirt that you have on? I'm just taking 2 minutes of our speaking time here to talk about Grandma. Beautiful Johns Hopkins Center of American Indian Health t-shirt. So I got one of these. Thank you, model. I got one of these from the center, and I was wearing it at home, and I ended up having to give it to my grandma because she loved it so much. So I do need another one. But she said, and she called me yesterday, she said, oh, I told your uncles you were going out there, and we wondered if you could bring back a few of those nice t-shirts. So some of the uncles you'll see in a later photo. And then the new love of my life, my son here, but this little puppy, we got this new little puppy and I just had to show him. Okay. And that family has led me to this family, which is our Gathering for Health research team. You can see here, some of us are Community Research Council team members, some are project interviewers, and some of us are university students and professors. And this is our diabetes team. We also have members of the Healing Pathways team, who I'll talk about in a moment here. Here's some of our elders getting honored at a blanket ceremony we recently did. And so I have the great gift that was given to me by my uncle, who worked with the original researchers from these projects back when I was still in grade school and high school. He gifted me the privilege of this partnership of doing research with our tribe and many others in the region. And I've now been engaged in research with our communities for about 17 years. And I'm going to share with you today data. So I think the gift of that partnership has produced so much information, more than we could ever fully put to use, which is a really tragic thing. But I want to share with you some ways that we're seeing family operating in a good way, in a protective way, in keeping with the theme of this gathering. So a little bit of housekeeping, family. I'm not going to define this term. It has been defined all morning. It's not just that nuclear family, as we've been hearing. But I ask this question, who is included? And I do that purposefully, because at the end of my remarks today, I want to bring up the idea of who is excluded. Because one of the things that I've been noticing over the past couple of years in our research with our community-based teams is that inadvertently, sometimes we're excluding people when we measure things in certain ways. And the amount of hurt and pain that causes even research participants is becoming more and more apparent to me. So I'll go there. But I really want to share with you in our data some examples of the mechanisms, I think, through which family can be protective, right? So we've talked about love and support, warmth and supportiveness. I think those are some of the parenting mechanisms. But we can talk more broadly about this network of social support It can help us promote a positive identity about ourselves, and I'll talk about that in terms of an Anishinaabe identity, which can be really diverse. This idea of mastery that is embedded in the community, that is, I can achieve things, but it's because of the help of my family and friends, and on and on and on. So I'm going to share with you, again, just some simple models today, nothing incredibly complex from a statistical standpoint, that maybe will plant some seeds and ideas and help to get some of our data out there. All right, I'm going to begin with Healing Pathways. This is our project logo. Very briefly talk to you about this study. So this study was what got me into graduate school. It was the one that my uncle was an on-site coordinator for back in the late 90s, early 2000s. And this project involved 746 American Indian and First Nations adolescents. And we talked to these guys from age 10 to about 18. So we have 8 years of longitudinal data spanning the course of adolescence into early adulthood. We also interviewed their adult caregivers, at least one of them, and in some cases two. And right now, actually, we're getting ready to go find those kids again. We're going to start field interviews this summer, and those kids are now in their mid-20s. So we haven't spoken to them since they were 18, so we've got these prospective data to talk about life course development. And so I'm going to share with you, one negative slide, and then I'm going to try to uplift us so we can go all hungry and happy to lunch. Okay. So we've been hearing about historical trauma quite a bit this morning. It's been a heavy morning in that way. And our team, one of the things we have tried to do is try to think innovatively about how could we, as researchers, measure this thing that we conceptualize as historical trauma. And the thing that we're probably most known for is my mentor, the original PI on this project, Les Whitbeck, worked with our elders to create a historical loss measure. And so if anybody has heard of that, you'll know that we try to tap into thoughts and feelings of losses. Well, another thing that we heard about, and you heard of this morning, is that intergenerational transmission of trauma and loss. And we tried to map this out. So I'm going to walk you through what is just what we call this path analysis, which is just a way of testing for statistically significant connections between variables. So let's start over here. If you can see the red dot on your far left, my right, relocation. I didn't hear a lot about the relocation era this morning, but that's another significant time in our history in this country when Native families were either forcibly or voluntarily removed to urban areas. I say forcibly because it was never maybe doctrined in that way, but we know many families felt forced to move into cities to try to get jobs, get employment. There was lacking opportunity on the reservation, et cetera, et cetera. So there are many cities in the United States where a lot of Native families landed. And what we know from American Indian studies, our history books, our lived experience is that this was not a real easy time, right? Families were separated from their extended kinship networks, their cultural ways, and it was really hard to survive in that environment. And so what our team did was measure, did your family, your grandparent, go through this relocation experience? And if they did, what we found is there was a linkage to the grandparent having alcohol problems, which was linked then to the current generation of caregivers, so these are parents, having CESD as a measure of depressive symptoms, so depression, and also linked to the caregiver having their own alcohol and drug problems, which was linked to then the way that the caregiver parented. This is all just a model. This is all just statistics saying what you already said this morning, right? And then ultimately what this led to, and there's a little typo there, but youth delinquency and youth depression. And we were able to model some intergenerational, what we call indirect effects that did span those 3 generations, and they were rooted in this one historically traumatic event. And you can imagine this happening for all sorts of anchored historical events. But I wonder, and I want to talk for the rest of this morning about what if it wasn't a negative path model, right? What if those intergenerational transmissions were of positive things? Because we know the reverse can happen too, and there's a lot of theorizing in terms of life course perspectives and linked lives and how things get transmitted. And actually in warm and supportive environments, in optimally, or in places where you feel attachment, that's where things really get transmitted in a good way. So hopefully we can build some of those models. But before I go into, or I'm not going to actually show you the positive model, I'm going to show you other kinds of positive models. All right, so back to, there's Grandma again. This is my Uncle Gary, by the way, the one who got me into graduate school, the reason I'm here. So I have to show you his photo, and I always will. And if you ever look up the historical loss scale, he's an author on the paper, Gary Adams. So that's him. No PhD. No, yeah. We don't need a PhD to do some of this. Okay, I digress. You can tell I'm proud of my family. All right, so measuring culturally specific protective factors. One thing I've talked a lot about over the years with my mentors and with our community team is this idea of Indigenous parenting, quote unquote parenting, as a potential protective factor. And if you go to like the family literature, and in my case, I'm a sociologist, so if we go to the soch of family literature, you're gonna see constructs like warmth and support, approval, monitoring, discipline, and they're measured in really Eurocentric ways, right? Like how often does your mom or dad know where you are? How many days out of the week do you have a set bedtime? Et cetera, et cetera. So that is actually the way that Healing Pathways originally tried to measure parenting. And you might imagine it didn't work all that well. Warmth and supportiveness actually was a construct that did hold up. But when I talk about the original PI, tried to measure parenting with just these kind of Eurocentric measures, it wasn't predictive of many outcomes. So what the team went to with the community's input, imagine that, is trying to measure extended family influence. And so in this table on your left, what you see are the percent of family members who were mentioned by the kids in this study as involved in their lives in terms of these parenting constructs. So as a quick example, if you look at warmth and support at wave 1, about 80% of the kids in the Healing Pathways study, so these are First Nations and American Indian kids, said, Mom is involved in being warm and supportive to me, with different indicators of warmth and supportiveness. Dad, 40% of the time. Sibling, 25%, auntie, uncle at 14%, and you can kind of go on down the list. So lots of people involved. There's a lot of extended kin influence, but what's kind of hidden here, and I just want to take a brief aside, is who does it the most, right? So I think that most of us could say that, well, I don't know. I know I can say that in my upbringing, I had a huge village of people involved, and I would nominate them in a ranking like this. But if I had to choose who was most involved, who would I say? And what we found was that when we asked the kids, for example, who was most involved in being warm and supportive to you, 63% said it was my mom most of the time, and only 11% said it was dad. So that's a big gap, perhaps, or an opportunity that's missed, and I think is in keeping with the theme of the remarks for today, that we have an opportunity there to fill a gap. Okay, there's a quote on the other side of the slide from one of our elders that she's talking about, the lingering effects of an extended family culture that remain with us today. One thing I didn't explain to you is this wave is just the different years of the study, right? So at age 10, 11, 12, and about 14. And then we kind of followed it as we went. One last thing I'll say is parental monitoring, the way it was measured in this study, never really predicted anything the way it should, unless we operationalized it as a count of how many people. So it didn't matter how much monitoring you had, it mattered how many. Again, that extended kinship being protective, an opportunity that these home visiting programs and involving extended families affords us. So what this has led to is, for over 20 years now, this program, Listening to One Another, which is a family-based prevention program for drug and alcohol abuse. And I'm not going to talk about this now. This afternoon, you're going to hear about a similar program. And so this is just to say that I see research and the great wealth of data that came out of Healing Pathways as a tool for funding, a tool for policy influence, and a tool for programs like this. All right, so what I'm really going to spend my time on this morning is actually diabetes, which we haven't really talked about this morning, but diabetes, I think you saw it on an earlier slide, is a health inequity in many of our communities. Dr. Warren talked about amputations, talked about his family. In our area, American Indians have diabetes about double the rate of the non-native population. And so our team has been engaged in a couple of different projects, really looking at mostly actually how stress influences diabetes, but how family and cultural factors can mitigate those stressors and their impact. So I want to show you a few examples. So first, we asked people in our studies, in both of those studies, who helps you the most to take care of your diabetes? And there were 3 modal categories that I want to mention to you, and they're not shown here. Number 1 was family, and people would say things like, my sons and my daughters, my aunties, my uncles, but mostly it was a spouse. So family. The second category was nobody. A lot of people said, nobody helps me to take care of my diabetes. Again, that's an opportunity for us, right? If these home visiting programs, I know that the center here is involved in. And then the third category was my doctor. So engaging with primary care services as well. When we did qualitative interviews in the form of focus groups with people, we heard about the need for social support and who helps them a lot. And so we asked them, how do you cope with diabetes? And they would say things like, spending time with my children, that's what helps me. Or if I could be involved in more community events, because I try to hit them all. And then one person said, well, around here they have groups for alcoholics, they have groups for people on drugs, they have groups for parenting. Lots of groups going on in our communities. But why wouldn't they do that for us with diabetes? There's lots of people with it. By the way, a side note, every time we do focus groups around diabetes, people never want to leave them, A, and B, say when's the next one. It's just a natural form of community support that they love. All right, a couple of really quick, apparently I like path models today, but I like pictures. So we wanted to find out, and this isn't published, this is just data that actually I ran to share with you all. Wanted to find out what are some of the things that influence following, for example, an exercise or a diet plan. So the special diabetes nurse at our tribe has told me time and time again, I can get people to take their medication. They're good at that. I can't get them to do the diet. I can't get them to do the exercise. So very early on in our work in diabetes, we were really interested in what influences diet and exercise. So we put in what we call a mediating idea here, this idea of positive mental health, using a measure of flourishing status. Doesn't that sound nice? And by the way, side note on this as well, our communities have rates of flourishing mental health that are off the charts. I'm talking about like 30-40% higher than what you see published in other studies. And we've replicated in 2 different unique samples now. So I can take that to the bank, I feel like. So we're happy people, we're good, right? And we're also depressed at the same time, so the contradiction. But we've published about that. It's not really black and white. Okay. Anyway, so this measure of positive mental health as a mediator, and this variable communal mastery. With the support of my friends or my family, I can achieve the things I need to achieve in life. With the help of those who love me, I can get it done. Those are the kinds of questions that form that construct. So what we found is communal mastery increases one's degree or reporting of positive mental health, which in turn is related to increases in exercise and diet plan adherence. And we do see close to significant or significant indirect pathways starting at that communal mastery variable, again, a family context variable, cultural context variable, going through positive mental health improvements and then changing the way that people behave. We found the exact same thing when we threw in a variable called family support, which we've been talking about all morning, so I won't explain what that means. But in this scale of family support, same kind of processes. I almost said processes because I've been with some of my Canadian relatives lately. Processes. Now here's an example from the same data set where we were trying to measure levels of what we call diabetes empowerment. And this is an interesting variable. We're finding that people who have higher levels of, it's kind of a measure of patient empowerment, like I feel like I can do this, I got this, I can take care of my diabetes. It's a really good mediator of all sorts of physical health outcomes, and so for that reason, it's an interesting variable to study. But we wanted to see how do these kind of cultural and family support factors interact to predict diabetes empowerment. So I'm going to walk you through this interaction. On the bottom here, we have a measure of diabetes support from friends and family. So who helps you or how much helps you get to eat well, to exercise, et cetera, et cetera. So low diabetes support all the way up to high. And what you can see in the 2 lines up above is regardless of one's level of ethnic identity, or in this case, cultural identity, as diabetes support goes up, you feel more empowered about it. So it's, that's not earth-shattering. We would expect that to happen. But what's really cool is that those with high Anishinaabe identity, so that's this top bar, that impact is much more pronounced. So you can see the slope is much steeper. Like, whoa, look how empowered those guys are. So if you've got both high support and high identity, you're the best off. And actually, if you have high identity but low support, you're still pretty dang good. You're still doing almost, I can't tell from here, but about the same as people with high diabetes support alone. So these things are separate constructs we find when we try to measure them. I mean, I think one of the things I've been toying with is how do culture and social context kind of come together and fall apart? How do they offer unique things to make us healthier? And I think, I don't have the coefficients up here, but these two ideas, the idea of positive ethnic identity and having social support, they're correlated, but only modestly. And they interact such that having both of them makes for a much happier life in terms of diabetes empowerment anyway. And we measure this in other ways as well. Okay, I want to take just a moment to, I think what I'm saying so far is like, yeah, that makes sense, right? But some data to back it up. But I do want to just mention the cost of caring. So this term, the cost of caring, is one that's used in sociology a lot, and you've heard it probably in public health disciplines or others. Sometimes it can be hard to be a social support person, right? We just heard about the grandma that you talked about who was, or the great-grandmother who was taking in her great-granddaughter, or great-grandson, and how difficult that idea was for her. And we hear this too in our qualitative interviews. I feel like, on both ends actually. On the top, I feel like a burden to my family. People constantly talk to us about, I don't want to ask for help, I'm trying to hide that I'm sick, I don't want to. So a little bit of pride, a little bit of fear of being a burden. In addition, we hear people saying, yeah, it's a constant battle. It took all of us to take turns, the grandchildren, the children, the nieces, the nephews. Oh, and those grandchildren too. It took a lot of help. And then he wouldn't want that help because, he wants to keep confidentiality and, he has his modesty too and things like that. So this is a very complex thing in modern times, tapping into these extended kin and support networks without feeling like you are a burden, A, and actually burdening, B. So how do we do these things? That's going to tie into what I have to say in my conclusions for today. Let's see. Okay, so having said this, there's a cost of caring, and yet maybe the best buffer of that cost of caring or family stress is more family. How can that be? Real briefly here, I think this is my last statistical model. I know I'm throwing a lot of numbers at you. This was something that our team has shared with some colleagues in the room at a conference in September and has written a paper on recently. But basically what we were trying to predict here is just the idea of caregiver stress. And in this case we were looking at parents. How stressed are you? Higher scores means higher caregiver stress, right? And so what you can see is there are 3 sets of models here. The first one tells us that people who are living on reservation versus off, so these are all native folks in Minnesota and Wisconsin in this particular sample, but some live off reservation land, okay? They all seek care at IHS facilities on the res. If they lived on the reservation, they were less likely to report caregiver stress. Interesting. In the second model, when we stepped in ethnic or cultural identification, it wiped out the effects of reservation status, and now cultural identification becomes protective. Those who are more immersed in Anishinaabe identity had lower caregiver stress. In the third model, when we stepped in that family support variable, it accounted for all the variants that we saw up above, and now that's the protective factor. But what all of this says is that these cultural and family contexts are excellent buffers for caregiver stress in this sample of patients with diabetes. And I think also in a broader sample as well. Okay, I lied to you, but they're just bar charts. These are easy. These are the last 2 bar charts, I promise. Okay, we heard about ACEs, adverse childhood experiences. I was gambling on the fact that I wouldn't have to explain that, and I think we're okay. I think we understand what that is. Good. So what you see here is in our, this is a sample of about 200 adults with diabetes, so type 2 diabetes. And down on the bottom here are quartiles within the sample. So all that I did was slice our sample into the bottom, second, third, and fourth quartile of scores. Okay, so it doesn't mean 0 ACEs, it means the bottom quartile of ACE exposure. First quartile, second quartile, third quartile. And I just plotted here self-rated mental health status as an example. We've done it with other variables, and this pattern kind of holds up pretty robustly. Not 100%, but it holds up nicely for a lot of outcomes. So self-rated mental health status. So higher bars mean higher mental health, self-reported. And what you should notice here is that as people with low social support increase in their exposure to ACEs, generally, and because of the smallish sample size and splitting numbers up a lot, one little what we call an outlier can really cause numbers to jump around. So just really kind of look at the big picture here. But what you can see is people with low social support, as they get more exposure to ACEs, their self-rated mental health tends to go down. Now, the same thing is sort of true with some exceptions if with high social support, but here's the big thing. Look at the difference between the low and the high. There's a buffering effect going on. So social support as an adult can offset some of those effects of adverse childhood experience exposures. We found the same kind of pattern when we looked at, instead of social support, cultural identification. I mean, to the point of someone in the highest exposure category of ACEs over here, the 3, if they have high cultural identity, they're the best off of all. There's a whole literature on post-traumatic growth, on meaning in life and things like that. I think that this might be tapping into some of that, but it is to say, as I think the speakers this morning mentioned, ACE score does not equal destiny. And experiences throughout the lifetime can help to buffer those experiences and exposures. So my conclusions then, and they asked us to give recommendations, and then you can have, well, I don't know if you can have lunch. I think he wants you to have some question time. But a few quick conclusions. I say this all the time because I'm a researcher. The way we measure things really matters. I really believe that. What we define as family and family influence and how we assess it influences the conclusions we draw. And this is where, briefly, I told you at the beginning, I'm going to ask you, or I'm going to bring up this idea of who do we leave out? So one of the things that our team has been doing over the years is trying to measure this idea of enculturation, or being involved in your Anishinaabe culture. And I have heard story after story now, to the point that we're expanding the way we measure this, of participants saying to their interviewers, well, I never go to powwow. I don't speak the language. I don't bead. I haven't done that since I was a kid. Sitting next to Community Research Council members who say, that's never been taught to me. I didn't have an opportunity to do this. And feeling sad and feeling like, well, I wouldn't show up in your measure of what it is to be a real Ojibwe person, but here I am. That's true of family as well. Who are we including? Who are we excluding? The extended kin idea is an obvious one. But there's much, much more. There's great diversity within our tribes, great diversity in who we welcome into our families, and we need to include them in those measures. I put as a recommendation here, engaging with experts across cultures and disciplines, experts including community members. I think that's what this gathering is doing for us. When do I get to hear from a tribal judge, a police officer, and a researcher, and others all in the same day? Very rarely, and I am excited and thankful for that. Finally, to be truly effective, I think that programs that have that social support contingent, and a lot of us are moving towards those types of programs, probably need to figure out how to support the supporters. And the evidence from our data, and I only showed you a few slides, we've got many papers published on this topic, is that it seems like both culture and family are tools to engage social support mechanisms for the supporters, the ones who are giving the caregiving. And finally, that gender-responsive programming may be needed, given those gender differences in caregiving that I brought up early in the slide. Gotta thank those funders, because they're in the room here. I see Aria, I see Kathy. No, actually, we really do. We couldn't do it without you guys. We appreciate you, Miigwech, and that's all. Time.
You all come up and we'll do a round of questions for 15 or 20 minutes or so. And, you know, the caregiver support that we sometimes may not be as aware of. Is there, Chair, Crystal? Crystal, go ahead. May not always be as cognizant of as we should be is an important reminder. And that includes folks like Dr. Santosham, who spent his entire career with us. His entire career helping American Indian Alaska Natives. And certainly Dr. Bullock and the work that she does at IHS is really important. And there's a fair amount of stress there, I think. In fact, I stretched it out just a second ago when I said Admiral Buchanan's going to be here. I'm going to speak to him before he speaks about what she did today. She got a little worried, but I was just giving her a hard time. At any rate, we have time for questions of any of the panelists. So just quickly raise your hand. We'll get a mic to you. There's two back there. We'll go with the woman first, because I think she raised her hand first.
Thank you. I'm going to ask this question, and I don't mean it as a criticism. I've run into the same issue myself in my own research. I think, as you mentioned, it's important to consider how we operationalize variables, particularly when we're using them in cultures, various cultures. And for example, I noticed that the CESD was given as a measure that was used for depression. And the CESD is a fine measure of depression. But to pick up depression in the grandmothers who attended boarding school is a very different experience of sadness, I think, than depression that someone experiences in current life, absence of resources, low mood kind of depression. I think it's a different construct. And we try to tap it using this same measure. I think we do it because reliability and validity reasons. I think we do it because it's a way for us to garner funding, because we have to get through review boards and we have to show measures that have been useful and we have to explain our constructs. So I just think when we talk about the constructs that we're trying to evaluate in Native American communities, and we have so much difference in the different Native American communities, how do we operationalize those variables in a way that's really meaningful? And I also think the linear models are what we're all trying to do, and that's what's accepted in the canon, but they're not linear relationships. And I think, how do we think about the complexity of historical trauma, intergenerational trauma, current life trauma, poverty, lack of resources, grocery stores 100 miles away? All those kinds of factors are influencing what's happening in the communities and in people's lives, and they're not captured in linear models in the way we do them. So again, I don't mean this as a criticism. I've run against this myself, but I just wanted to raise it and hear your thoughts about it.
Yeah, ditto. I mean, ditto. I talk about this a lot. I think we've written a paper about this issue with a couple of others in the room about measurement. Okay, just briefly on the CESD, I don't love that measure because it's long relative to some other measures of depressive symptoms. A couple of things. One, in terms of validity, I agree with you. I think there are other phenomenon going into depression cross-culturally, and there are many people who do excellent qualitative work on that topic. CSD does hold up in our sample in terms of predictive validity, in terms of reliability, so we had continued using it in that particular study. But having said that, in many studies of American Indians in the US anyway, and this isn't all of them, but what we have been noticing is that when you use a clinical diagnostic interview, like a structured interview to get to a DSM diagnosis of depression, our rates of depression are actually not so high. But when you use a screener like the CESD or these other measures that are shortened screeners, our rates of depressive symptoms are way, way higher. They show up as a health disparity. And so that's tapping into this issue that you're pointing to. What are we getting at? Are we really picking up on maybe stress or bereavement or other things? But we've been talking forever about a measurement study, a big one.
Thank you. Maybe Officer Pooley, maybe you could mention something about how you relate to stress in the situations that you put yourself into sometimes in your work.
Well, I'm not a researcher, so I don't want to talk about that. But this is more, I guess, not really academia, but more of a practitioner. I do. When you go to a high stress call, you will see, I guess, immediate impact on the family. What happens afterwards, I don't know. I know we have other things such as social services, or we have community crisis workers that will come out to help with the situation. But as a resource, I don't even know if I'm answering that question right. But yeah.
The other gentleman had a question?
Hi, good afternoon. This question is for Ms. Melissa Walls. I'm sorry. I like that when you ended your presentation, you were talking about exclusion of certain populations within our communities. Can you expound upon the gender differences and the gender identities of people we may be excluding, other than the colonialized binary of male and female in our communities, and how that impacts chosen family rather than given family?
Well, I will say two things. One is, I think that, so for the first 8 years of Healing Pathways, I bet you could guess how gender was operationalized. Male, female. We have the new study, and our team has been open, we have a group of elders who have been on this project for 17 years. And I said, I'd like to measure gender identity a little differently. They said, go for it. So I think that our communities are starting to notice what happens when we exclude people of different gender identities, sexualities other than quote-unquote heterosexual, and so on and so forth. So I think we've done a horrific job in our studies, and I hope to try to do better. But that's exactly part of what I was thinking. Who are we excluding when we fail to even ask?
Tamara?
I always forget that. I appreciate and enjoyed the work that you were doing on the resiliency and protective factors, and I'm wondering if you have collaboration or work with some of the juvenile justice systems. I know they're often looking for ways to evaluate, the youth and their remediation programs, and they're lacking that information, I think, when they place our children in their systems.
Is that
Yes, Mark, Ann, your data, your area.
I do agree with you. For the youth, when I was a tribal prosecutor, there were a lot of kids that were, just like the judge was saying as well earlier this morning, that a lot of our youth are being incarcerated way too young and way too long. A lot of times what I found is if they couldn't find a placement for foster care or youth home, I hate to say it, if they committed a crime, they were put in jails. On contrast, I actually am a police officer in a major city in Arizona, and for us, for the non-native community, they have to do something horrendous, almost commit a homicide for them to be incarcerated. If they commit even some violent crimes for domestic violence, they may not even be put into the system. They're in the system, but they would be released pending, meaning that they wouldn't spend one night in jail. And so you could see a big contrast between both communities, the native and the non-native. They're just big differences. I don't know the answer to it. I don't know if that's how it has been like that historically from the beginning and just hasn't changed, or I don't know the answer. But there is a big difference, and I think for especially our youth, before I was a police officer, I actually worked for youth services and worked in a group home. And this is more, again, a practitioner. Even being in a foster care or even in a youth home, at night you would hear the kids crying in their own beds, and it's very sad. And so talking about the trauma, it's real. Again, I'm not a researcher, I don't know all that stuff, but as for a practitioner, I know that the trauma is real and it's in our communities.
And Allison, I'm sure with the Family Spirit Program been going on, you've had
I actually was going to mention, so the White Mountain Apache tribe did an incredibly novel thing. They have created a community-based surveillance system for binge drinking, drug use, and suicide. But as the police respond to incidents where youth are involved who may be suicidal or had a binge drinking or drug episode, they then reach out to a community mental health worker team in their communities and pair those families with a case manager. Really unique program, and they work so fluidly between law enforcement and community mental health. So I think it's a great example. And how tribal sovereignty really makes a difference. The White Mountain Apache tribe in Arizona, and again, the tribal council mandated reporting of suicide and binge drinking and drug use, and also the development of this community mental health team linked to law enforcement.
Anyone else? Yes.
Well, I noted that both in the home visiting and I think in this last presentation, I just wanted to commend the use of community members themselves in the solution. And so I just wanted to note that because there's so many funders in the room, but also, even your uncle didn't have a PhD, but he's still, value and can contribute. And I just find that that's always a way. Also in teacher recruitment, we've really seen that as well. Somebody else said that. I think the woman who spoke about the home visiting, homegrown people from the community, from Chinle, who they know all the community members. I mean, it really is the best solution. So I just wanted to note that. And then also the things that you measure, and that with trauma, and maybe the next step with that would be looking at their environment as opposed to looking at the individual, but because it's not always within them, right? It's what is their social context. And so, the depression in that environment and that in that context as opposed to just within that person. And that, to note the White Mountain Apache tribe on suicide, I think that just came out from you guys, I think is where I saw that email. And looking at their social context of those folks who had attempted it as opposed to just looking at that individual because they are clearly merely a member of their bigger community. Thanks.
Next, we had a couple more minutes. I used to work at the Bureau of Indian Affairs. Go ahead, I'm sorry. Go ahead. I was going to mention a visit I made one time. Go ahead.
Good morning. I work for the Protective Services Agency for the state of New Mexico, and I just want to thank everybody on the panel. But I was particularly interested in Dr. Walz's information on connections and family support systems. We in New Mexico are currently in the process of revamping our safety assessment process with families, and a key part of what we're trying to do with families is say to our families, if you don't have a support system, go out and find one. Create one. Because we think that that's a key element to families being reunified and staying together. So I was really excited to see your statistics because, like you, I'm not a research person, and so thank you for doing the research that shows us that we're headed in the right direction with, I think, what we're trying to do. But I guess my question is, how can I get some ideas from the panel about how we do that in an urban setting? We have, of course, lots and lots of families in Albuquerque and Las Cruces and Santa Fe that are disconnected from the tribes. And as others described, some families that don't want to be involved. I wasn't raised traditionally, and so I don't want that in my life. I don't want to identify as Native, and sometimes they say I don't want to have anything to do with my biological family because they represent that Native part of me that I'm trying to disconnect from. So I guess just any ideas on how to get families more engaged with their tribal communities and cities?
Yeah, so I live in the big city of 80,000. That's a big city to me. So that's urban to me. So I think it's that idea of how do we define family? How do we define support? And I know that most of the bigger cities have, some really nice urban Indian centers, and people like Joe Gahn, Amy West. These are names that, if you Googled them, I think they've done some research on promoting health in urban Indian areas. Trying to think who else. Dan Dickerson as well. Kulis, Kulis. I can give you all these names after or actually even Arya behind you. She's got a whole list of names. All sorts of unique, innovative strategies for engaging community and creating family that doesn't need to be biological, as you point out. That's just a quick thought.
I think there's a big contrast between the rural and the urban populations. I think in the rural setting, I think families are a little bit easier to grab from rather than the government agencies. I think it's the complete opposite. Like I said, I work in a big city, and when we do go to a crisis, either through mental illness or a suicide or a family, anything of chaos or a tragedy happening, we usually have at least 3 or 4 state, federal, or even private entities that could come in and help pick up that slack. Even if setting something up as a funeral, if someone passes away or commits suicide, we're able to pull these different agencies. So I think in an urban thing, such as in New Mexico, use your federal or use your agencies that are there. But saying that will only last its short-term fix. We call it a Band-Aid. At the end of the day, you do need to have longer programs that will address the family's real needs. And that, again, our whole conference here is that underlying issue of finding someone's self-worth and getting that support from the family. One last thing is, a lot of people that I come in contact with are transient, people who are homeless. And there comes a point where even the family doesn't want to work with them. They've burned all those bridges. And so that's where, again, the government will come in and hopefully help that person renew, I guess, their own self-worth. So I don't know if that answers your question, but that's what I was thinking.
So we have several affiliates who are actually based in urban areas. And I think a big thing from our model has always been the motto of meet them where they're at. And so our curriculum actually really brings up dialogue that allows families to define where they want to go. So these are values, these are principles, these are things that are protective in helping them to remain and to create strong families and kinship with one another, whether that is their biological families or not, you know. And so, you know, our friends in Oakland, California, at the Friendship House, it's an amazing place to kind of be able to observe the different type of culture when American Indian tribes, you know, over 200 tribes that come to this place, that come together, and then they define who they are as a people. You know, a lot of them were coming from different tribes, and they've really adopted the different practices, you know, and they share that, and they really have made it their own. So family spirit in that sense has worked really well with that community.
Thanks. You know, this research, these kind of studies, these kind of evaluations, these kind of look-sees at American Indian, Alaska Native communities is going to happen with or without us. With or without us. One of the first real looks at Indian country was done by Bob Kennedy before he was assassinated in June of '68. His brother, Ted Kennedy, finished it off. It was about education and how the lack of education really made a difference in how well we all did economically, socially, and such. It's a great report completed in 1969. And some of the similar kind of issues we're dealing with today are still there. But it begat a lot of different programs, a lot of scholarship programs for medical students and others. I know the first Indian person to have graduated from dental school, George Blue Spruce. I mean, I know the guy. That's the first one in my lifetime. At the time, back in the 60s, there were maybe less than 100 Indian physicians. Now there's close to 800. So a lot of things can come out of these kind of symposiums that I think it's responsible of all of us to give our best recommendations to the foundations that are helping us, and to Johns Hopkins to develop a report that we can use to hopefully leverage more support and gains that I think we're entitled to, so to speak. I think we're entitled, but I know that's not always a good word with Congress, but you know, Congress is there to serve us. So I appreciate everyone being here. Do we have one more? Please, go ahead. From Miss Fort Berthold of 19 what? I don't want to say, okay.
MHA Nation, Fort Berthold in North Dakota, Dr. Mayer again. Sorry, but I did this last time to you guys. I'm holding you up from eating, but I guess what I'd like to say as an ER physician for 18 years in the Great Plains area, I think that the biggest destruction to Indian families, and I think the #1 issue in Indian country today is drugs and alcohol tearing up families and children. Actually, I think the #1 issue in Indian country is health, lack of. The #1 issue within health is drugs and alcohol. So I have a lot of respect for the police officer because you know what? In Indian country on the res, we're so siloed. Again, I'm going to talk about silos because the police officer is typically the first one on the scene in the family home for sexual abuse, child abuse, domestic violence, drugs and alcohol, criminal activity, whatever. Then that ER physician, that PD, he's going to call the social worker if it's a child involved and get CPS involved, then get the court involved. And do you realize we got no funding? They flatlined it. Federal funding for CPS, domestic violence is all flatlined. We don't have enough foster homes to take children out of there and put them in the homes because the home is infested with drugs and alcohol. And then maybe not, though children are in there, then that person is going to go to the ER, and that's where we see them. Then the ER takes that client, and we can't really admit them if they're drug and alcoholed out to the hospital because we're not equipped to handle that. IHS don't pay for referrals for treatment. They don't have any insurance because it's usually a male that's not employed. And so what do we do with them? On the reservation, our jails are our detox and our treatment right now, and our jails are busting out of the seams because they're full not only of adults, but juveniles now. And so I just saw CNN had a big special on the opioid abuse in the United States, and Trump's got a plan on that. But I'm here to tell you that drugs and alcohol is destroying Indian children and families, and we need a mapping process to be done to figure out how we're gonna handle that. And I just don't know how to do that, but those that are doing research, that sure would be a good idea, wouldn't it? Thank you.
Thank you. I think lunch is next door?
No.
Oh,
So,
sorry. Go ahead, Allison.
just quick response to that. These data show that the way you break the cycle is early childhood intervention with promoting parenting skills. The parents abuse substances less, and their children have much lower reduced lifetime risk. So I think there's a lot of promise in early childhood intervention for these issues. And I think Native communities are so open to family-based work. So I think the culture and value systems are so intact to address it in this way.